This is Diana Arias with the Community Technical Assistance Center at NYU's McSilver Institute, and I would like to welcome you to today's offering, Optimizing Treatment for Youth Anxiety and Related Disorders over Telehealth with Dr. Emily Becker-Hames. We are very excited for this offering because the use of telehealth as a service modality for delivery of mental health care and treatment drastically increased in the last few years. And this quick pivot to telehealth may have left many providers wondering how to utilize this modality to meet unique mental health concerns. So again, thank you for joining us. We are very excited to again have with us Dr. Emily Becker-Hames, Clinical Director of the Pediatric Anxiety Treatment Center at Hall Mercer and Assistant Professor at the University of Pennsylvania's Center for Mental Health. She is an implementation scientist and psychologist whose research and clinical work is dedicated to improving mental health service quality for youth. Dr. Becker-Hames has particular expertise in the implementation of exposure therapy for pediatric anxiety and obsessive compulsive disorders across settings, and the application of exposure therapy for youth with complex comorbidities. So again, thank you for joining us. I am now going to pass it along to Dr. Becker-Hames to get us started.
Thank you so much. I'm very delighted to be here today. As Diana mentioned, this is some topic that I'm super interested in, spend a lot of time thinking about. So very grateful to have the opportunity to share with you all today. Before I formally start, okay, we move forward slides, let's go, there we go. I want to just have some acknowledgements that a lot of the content that I'll present today is not necessarily developed by myself alone, and some, not all, but a lot of the content that I'll talk about is actually from a recent manuscript that some colleagues and I put together specifically on this topic. And later on in the presentation, I actually will have a QR code that you can use to access the free version of the paper and some resources that are included there. And I did just want to take a moment to acknowledge my co-authors and other members of the Patch team that were instrumental to this work: Samiha Islam, Dr. Amanda Sanchez, Cassidy McDermott, Doug Clapp, and Dr. Julie Worley. So with that, I am excited to dive in. And before I get into talking too much, want to just get everyone's brains thinking and maybe hear from everyone a little bit in the chat. And if you see my eyes go this way, it's because I have the chat open on the other side of my screen. Just take a moment and type in very briefly what a concern that you may have or a challenge that you've experienced in providing telehealth services to kids with anxiety. And I'll take a minute for those to come in, and hopefully we'll get to most of them as we go through today and what that means. All right, so I'm seeing some engagement issues, questions around distraction, not wanting to engage on camera. Excellent. Distractions at home. Keep them coming. These are great. Motivation, engagement. Okay, so big theme around engagement. So we'll definitely talk more about that as we go through. This is excellent, and everyone's sharing many things because there are a lot of challenges about doing telehealth with kids with anxiety. So let's talk a little bit today about how what we're going to talk about will hopefully address a lot of the things that you all are bringing up in the chat. Excuse me, I'm getting over a cold and I have fall allergies, so I apologize for coughing as we go through. But here's what I will hope to accomplish over the next hour or so, and then make sure we save time for questions, is start just by reviewing some background information to get us all on the same page about what gold standard psychosocial treatment for kids with anxiety disorders looks like. And no, I use the term anxiety and related disorders to refer to any treatment where there is a hallmark characteristic of avoidance that contributes to the difficulties a child is facing. So common diagnoses I'm thinking there are any anxiety disorder, obsessive compulsive disorder, and some potential implications for post-traumatic stress. And I'll talk more about that as we go through. Then I'll get into big picture, what the evidence is from the research literature about how effective telehealth is, as well as what the limitations are of the current evidence base and what we know from research. Then we'll really dive into some guidance, really practice-informed guidance for recommendations for working with this population, and talk more specifically about how shared decision-making can really support implementation of those recommendations. And then hopefully we'll have time for at least one, maybe up to 3 case examples and for questions. Okay, so let's dive into the first objective today, which is to talk a little bit about some gold standard treatment for youth anxiety and related disorders. And I want to start off with a little bit of background. This information maybe review for many of you, but I want to make sure that we're all on the same page. So first, when we think about treatment for anxiety, one of the first things that I always tell kids who come in my office is that our goal is not to get rid of their anxiety, right? Because anxiety, everybody has it, unless I say to kids, unless you're a secret robot, and no one's a secret robot. So everybody experiences anxiety at some point in their life. And that's for a very important reason. And that's that anxiety keeps us safe from harm, right? If I could wave a magic wand and get rid of anxiety, you wouldn't think to get out of the way if you heard a car horn honking at you as you cross the street, because that signals to us that there's danger and we need to do something to get away from that dangerous situation. Similarly, anxiety also motivates us to do things to stay healthy or be successful. So if I find out that I have a math test tomorrow and I know none of the content that is on the test, it's probably good for me to get a little bit anxious, because then I'll be motivated to actually study. Or in more of a personal example, I say there's no way on earth I'm going to go to the dentist unless I'm a little bit afraid that my teeth will fall out, because I don't want to do that, but my anxiety makes me do something to keep me safe and healthy. So everybody gets anxious sometimes. But as I'm sure we're all more than aware, for some kids, and estimates have historically been about 1 in 4, although that number is certainly rising in the wake of our current youth mental health crisis. But many kids at some point will experience significant anxiety, where that alarm that warns us that there could be something dangerous happening, that we could be in trouble, that we need to motivate ourselves to do something, is too sensitive. And it goes off at extra times, not just when the times it needs to keep us safe. And when it does reach those points, and that's where it's impairing, that's when we call it an anxiety disorder. And we care about this for a lot of reasons, but importantly, there are key public health and mental health implications if we don't catch and treat kids with anxiety disorders successfully. So to just highlight a few, right, anxiety is pretty impairing for kids. It can really impact them and keep them from doing things that they want to do, meeting their goals, living a values consistent life. And we call that functional impairment. And we also know from a number of studies that kids with anxiety disorders are at risk for educational and occupational underachievement. And for also, they're more likely to experience other mental health conditions like depression and express higher rates of suicidal ideation, as well as demonstrate higher incidence of substance abuse problems. And then importantly, we know if we don't treat them, it's unlikely they'll go away on their own. And that youth anxiety is also predictive of future anxiety into adulthood, as well as depression, suicidal ideation, and other mental health concerns. So obviously, as again, I'm sure this is review for many of you, we want to make sure that we're effectively helping kids with anxiety. One thing that can be tricky with anxiety, as I mentioned, is because everybody has it, sometimes it's difficult to differentiate what normative fears and worries are that we wouldn't consider pathological, we wouldn't necessarily treat, from those that are consistent more with an anxiety disorder. And the goal of this talk is not to really be on assessment of anxiety, but I just say this to note that when we talk about anxiety treatment, we're talking about the anxiety that doesn't fall into these buckets, the anxiety that doesn't reflect that normative fears, that is more of a problem. And here you can just see some common fears and worries that are typically reflective of normal development. Excuse me, like for example, in preschool kids, we expect them to have fears of the dark. We expect them to have fears of monsters. That's not pathological. That's not something we would necessarily treat unless it escalated to a point that it was significantly impairing, or if we start to see anxieties emerge out of sequence, right? Like if we're seeing significant fears of the dark in the adolescence age, that would be more concerning. And overall, some big picture signs, right? When we talk about anxiety, we would want to treat, we're looking for things where it's developmentally inappropriate, right? That maybe like a fear of the dark that's sort of outside that realm of typical development that we would expect. And importantly, that it's pervasive, meaning that it exists across multiple contexts, right? So I think a good example is maybe a kid who shows anxiety in math class, but not any other classes, wouldn't be demonstrating pervasive anxiety. And in fact, maybe having difficulty with math, where their anxiety is actually understandable and maybe indicative of a learning issue, versus if that same child had anxiety across school settings and across other settings as well, that's more of an indication that maybe we're talking about an anxiety disorder. In addition, that anxiety would have to be persistent for it to be something that we think it would probably be a primary treatment target, because kids can have flares of anxiety over time and normal ups and downs with emotions that aren't, again, necessarily pathological. And then critically, one of the things we're looking for is, does that anxiety lead to some type of avoidance behavior, right? Not wanting to do things for fear of what could happen, where it's starting to mess stuff up for kids and causing that distress and functional impairment. So like I said, the goal of today is not to focus on assessment. I could do a whole other, like several hours on that. Feel free to email me if you have questions about it. I'd love to talk about it, but I'm not going to talk more about that today. What I will say is it can be tricky to accurately identify kids with anxiety, but when we do that, we usually can treat it pretty well. And the two frontline interventions for kids with anxiety is, first is medication, right? That is particularly the selective serotonin reuptake inhibitors are considered an evidence-based treatment for anxiety disorders. But the recommendation typically to start with for kids who especially may not want medication or need that route right away, is to start with psychosocial therapy. And in particular, cognitive behavioral therapy is considered the frontline intervention for anxiety disorders. Now, when I say cognitive behavioral therapy, or CBT, for anxiety, that's actually not as straightforward as it sounds. CBT is actually a broad umbrella term that refers to a number of different interventions and intervention packages that are guided by cognitive behavioral theory. And overall, though, CBT is considered an evidence-based treatment for pediatric anxiety, with about 50 to 90%, depending on the study and the treatment that they're used, showing good short-term outcomes, with many youth maintaining their gains up to 5 to 10 years later. That being said, there are a lot of different CBT protocols that you could choose from. So if you Google CBT for anxiety, there's a lot at your fingertips that you can use, and it's a little bit overwhelming. But fortunately, many of the CBT programs for anxiety that exist actually all do the exact same thing. They typically include some education about anxiety and how it manifests in kids, teaching people to notice their thoughts, providing rewards for brave behavior, learning to identify anxious thoughts. But critically is this ingredient that we call exposure, or exposure therapy, or exposure-based cognitive behavioral therapy, or exposure with response prevention. These are all terms you may have heard to describe that. I'm going to just stick with exposure for simplicity. And really, it's a treatment component in almost all research demonstrating positive effects for youth anxiety, and is increasingly understood as the primary active ingredient that leads to symptom change for kids, that really gets them the relief from the distress that they're experiencing. So what is exposure? For those of you who may not be intimately aware with that, exposure is different than sort of traditional conceptualizations of talk therapy, right? Exposure is what we would define as a gradual facing of fears, being to people, objects, places, internal sensations, or feelings in a supported way. And it often means going out and doing the things that can be a little scary or stressful for you. So that is a picture of me holding a tarantula as part of a training to learn to help other people manage their fears of spiders. You can see from my face that I'm probably not super comfortable with this, and also proud of myself for doing it, which I think is a great way to sum up how exposure works, because we're really teaching kids to tolerate fear, teach them to learn that their brains and bodies are safe in situations that they're afraid of and that they're avoiding, and that ultimately that they can manage their anxiety in a more adaptive way. Exposures have been studied extensively across a number of different anxiety and related disorders. I have them up here on the slide. I won't read them to you, but these are all different mental health conditions that exposures are the frontline intervention for improving symptoms for individuals. The exposures themselves may look a little bit different depending on what exactly you're treating, but the conceptual underpinning of trying to help people face their fears in a gradual and supported way are identical for all of these presentations. And again, this isn't a talk about how to do exposure therapy. If anyone's interested in that, contact me. I love to do trainings in exposure therapy. If I could do that all day, every day, I would. But instead, I'm going to just highlight a couple of guiding questions that we use to train individuals to think about setting up exposure practices. That really what we want to help clients do. And just so people know, I tend to use the word client and patient interchangeably, so you'll hear me use both as I talk through the rest of the slides. But in the context of exposure work, we want to help clients understand and develop insight into what is it that they're afraid of, right? And then importantly, is that fear leading to some type of maladaptive avoidance, right? Because we're not going to try to treat the ways that anxiety is helpful. Those alarms that we would call maybe true alarms, those signs that you do need to do something to stay safe or to motivate yourself to be healthy. And sometimes that's a process of a collaboration with families to understand, what is it that we're going to treat through exposure, what maybe incorporate other intervention strategies. But importantly, when we've identified things where there is maladaptive avoidance, we then want to help use exposure tasks to help clients learn something to overcome their fear, and then design and implement exposure tasks to help them learn that to the fullest extent possible. I have an asterisk up there about what does my client need to learn to overcome this fear, because this is an area where sometimes we need to check our own biases about what does and doesn't constitute maladaptive avoidance. So just to give a very overly simplistic example, I personally don't do great with heights. I have a little bit of a fear of heights myself. So when I'm treating individuals who also have a fear of heights, I have to be really conscious that my own anxiety sometimes filters how I interpret their behaviors. And I'm like, yeah, you should stay way back from the ledge over there. And that's what you need to do to be safe, even though that's probably objectively not true. And I have to be really thoughtful about how my own anxiety may filter my interpretation of my clients. Or to give another example, let's say that we think a child needs to overcome a specific social fear that they're really worried about, but maybe this is a child who's neurodivergent and has different social expectations and social goals than kids who are considered more neurotypical. And we may need to think about what parental expectations are, what societal expectations are, and what the child's actual expectations are to figure out what it is we're going to treat with exposure. So I'm going to leave that there. Like I said, I could talk about exposure for hours and hours and hours. Please, I have my contact information at the end, and I have some resources at the end. So if you want more of the how-to of exposure, feel free to reach out to me and let me know. But at this point, I'm going to transition to talking specifically about how do we do exposure therapy in the context of telehealth care. All right, so let's move into that. So what do we know about telehealth effectiveness specifically for kids with anxiety and related disorders, specifically when we're talking about exposure, which is a complex intervention to deliver, and then what some of the limitations are of the evidence base. So the good news is, before COVID, before our lives were upended and we had telehealth all day, every day for everyone we were working with, is people were already thinking about this, right? We know that telehealth is a great way to extend access to care. And so there were researchers who were thinking like, hey, we know exposure works for kids. And we know that telehealth can increase access. Let's test and make sure that telehealth exposure therapy works well enough that we should want to potentially think about doing that more. And the good news is most of the data suggested that when you do exposure over telehealth, you can get the same outcomes that we can get when we're doing in-person exposure therapy for kids with anxiety and related disorders. Now, I'll talk about some limitations of that in a minute, but the good news is we do have the data to suggest this is something we can be reasonably confident will be helpful to kids with anxiety and obsessive compulsive disorder or other related conditions. And as we all know, COVID-19 fundamentally changed, right, the landscape of telemental health service. It went from being very niche, that very few people were doing, was primarily happening within the research context, to essentially overnight, everyone's practice became a telehealth practice, right? So we had emergency provisions that went into effect that waived regulations that made telehealth more difficult. We were all stuck at home, so we couldn't go to in-person services, even if we had wanted to. And there were a lot of policies that were enacted over the past few years to really sustain those initial emergency waivers and allow telehealth to continue to be delivered, especially from people's homes, and sustain access and allow insurance coverage for telehealth services, where historically that was really difficult in many states for insurance to cover or reimburse for telehealth delivered services. And then in addition, right, we had some information about protocols that were available, but there were also a lot of gaps. There were only a few studies that had been developed that had been tested telehealth over exposure over telehealth. And so clinical researchers and people who are working in clinical practice put together guides and shared them out with others who are doing this work to give some clinical recommendations for how we can work with anxious kids over telehealth. And not to mention, I'm sure we can all relate that especially at the peak of COVID, at least in my practice and in the practices in my area, attendance overnight went through the roof, right? Like we had kids all of a sudden attending services all the time with a significantly reduced no-show rate. And there were a lot of benefits to telehealth that I think we all started to see. But as we all know, I would say everyone may vary, right, in whether you believe COVID has ended or it's obviously still around, but the global emergency has ended and life has resumed, things have reopened, and we're now in a position where we have shifted from doing telehealth by necessity to telehealth by choice in many instances. And as mental health providers, we now have three options, essentially, or modalities is the word that I'll use, for how we can provide care. So we do have, obviously, our traditional in-person therapy services. You can see an image here of a colleague of mine doing an in-person exposure to fear of dogs. We also had teletherapy at our fingertips, where we could work with kids over the computer or over the phone to be able to provide them support. And then we also have what we would call a hybrid model, right? Which is essentially where we're working with one individual over a course of treatment, where we may do some sessions in person and some sessions over telehealth. And so that hybrid model is something that really hadn't been fully tested, but is something that we increasingly see clinicians using for a variety of different reasons. So I mentioned before, right, we have good data to suggest that we can get equivalent outcomes when we're working with anxious youth and delivering exposures on telehealth versus in person, but there are a lot of questions that we don't know the answer to. Two big ones being, what kids are best for what modality, right? Are there some kids for whom telehealth is more important? Are there some kids for whom in person is better? Who is a good fit for hybrid? And how do we do the hybrid approach? What are the recommendations for that? There's virtually no studies. There's no recommendations out there for how to think about using a hybrid approach. So ultimately, what we know is it can work, but we don't have a clear roadmap for what we can recommend to clients who are sitting in front of us, the individuals we're working with, to make a recommendation for whether telehealth is going to be the best fit, or in-person is going to be the best fit, or a hybrid model will be the best fit for the individual. So that's where I'm going to move us to talking through is what we know and how we can make those recommendations to work with the individual clients or patients that we're serving. I will say, moving forward, a lot of my recommendations that I'll talk about and the information is very geared towards a pediatric anxiety or youth anxiety and related disorders population. However, a lot of the content, it also could extend to individuals with other presentations as well. So there's some things that are specific, but a lot of the recommendations, my hope, are things that you can also think about applying in a wider way. Now, that being said, I showed you these guiding questions earlier, and ultimately, no matter what modality is that we're doing, we want to make sure that we're serving our clients' best interests as much as possible. So ultimately, we want to think about what is it that our clients are afraid of, finding the ways that they're experiencing maladaptive avoidance, and thinking about how to help them overcome their fears. And adding into that, right, does telehealth help me do that more effectively? Does in-person sessions help me do that more effectively? Does a hybrid model? And we'll talk more about what that means. Okay, so ultimately, what I want to sort of open this next round of discussion by saying is that ultimately telehealth has both advantages and disadvantages for delivering exposure therapy. And I think it's important to be explicit about both of them because it's not always super clear, and there's not a clear rule of thumb that yes, we should always do exposure over telehealth, or no, it should always be in person. It's really a mix, and we need to think carefully through to make the best recommendations we can for the families we serve. So in terms of some of the advantages, there are a lot of very specific advantages to using telehealth with anxious kids. So most importantly, like I said, exposure is all about helping kids learn. And telehealth gives us a way to help people do practices in the very settings where they experience their anxiety. So for example, I do a lot of work with individuals with obsessive compulsive disorder who may have a lot of issues with in-home contaminants or concerns about touching things. And being able to do exposure over telehealth lets me coach kids to practice things exactly in the place where they experience the most distress, right? It also gives us an opportunity to really see clients in their home environment and get a direct view into how the family functions in their own naturalistic setting, right? Lots of implications and things we can learn about that for treatment and for exposure specifically. It helps us think about how we can design exposures again in that natural environment. It also lets us tailor exposures to naturalistic stressors that may come up on the day-to-day for the individual and vary the places that we're doing exposures. So not just doing them in an office that can feel safe, but maybe having the client take a walk out of the house and be able to, be on their phone getting exposure therapy and coaching with the therapist in a headphone. Or if they're afraid to take the bus, we can essentially take the bus with them if we're not able to leave our office in a way. For example, in my setting, I can't bill for a session where I'm not seeing somebody on site, but I can do telehealth with a client while they're on a bus and doing their exposure practice in a way that I wasn't able to do before COVID, before I was allowed to do telehealth in the way I am now. And for some individuals, telehealth really can facilitate access to care and engagement in care when getting on site is too difficult for a variety of different reasons. That being said, there are disadvantages, as I mentioned, to telehealth for anxious kids as well. So we know that exposures are, by definition, somewhat distressing to clients because we're asking them to face the things that they're afraid of. And there are kids who likely may have reservations about coming to sessions, and it can be easier for them, frankly, to avoid sessions over telehealth because they can just turn their camera off or just not show up. And it can sometimes be difficult to also conduct exposures that require kids to go outside the comfort of the home. One example of this too is like we do a lot in our setting of exposures to social settings. And when we're on site, we have a really nice ability to take kids down the hall and have them practice conversations with the person who's working at the front desk or who's working in the billing office and have real naturalistic opportunities for conversation and practice. That's harder to do over a telehealth platform. We also know that there can be a variety, right, in how much oversight a caregiver may be able to provide. So rather than requiring to provide transportation for their child to come on site, the kids in a telehealth session may log on to the video conference platform independently, and their caregiver is maybe home, but not necessarily present in the same way for the session, which can complicate telehealth delivery. As I mentioned, there's also opportunities for kids to avoid in different ways, right? Just like turning their camera off and not fully engaging. And it also can sometimes be an extra stressor for clients, especially kids who may be socially anxious and not want to appear on camera. So in some ways, it may be more anxiety provoking to do telehealth instead of coming in person. And then finally, one thing that's really important is in all therapy, right? And especially in exposure therapy is being able to read nonverbals, is how stressed or distressed somebody is by a given situation. And without that ability to fully read, right, you only have the limited view of the body that you get in the telehealth platform. That can sometimes present difficulties for exposure work. Excuse me. And then Finally, I mentioned hybrid models before, and we really, in terms of advantages and disadvantages, we truly don't know that much. So I have a quote up here by a leading researcher who's done a lot of work in this space, right? So hybrid options are those that involve some in-person components and some telehealth components. In his opinion, in a recent opinion piece, was that these are likely to fill important clinical needs going forward, but really we have no research on these at all. But let's think about some hypothetical benefit that we might have of a hybrid model, and thinking specifically about a client with social anxiety. And I want to think about these two advantages and disadvantages because it's really not enough even to say that social anxiety means that we should do one modality or another. It can be so much more nuanced than that. So in this first example, right, you have a client with social anxiety who maybe attend sessions in person a few times really to develop rapport with you, do some initial practices or exposures to different social situations, and then they transition to telehealth mostly for skill consolidation and working to maintain gains and prevent relapse. And alternatively, a hybrid model might look like somebody attending sessions by telehealth 3 times a month and then once a month in person for a variety of different reasons. Maybe transportation every week is just not feasible for that individual. And in that case, in-person sessions might focus specifically on teaching new content and doing practices within the office about interacting with others, while the telehealth sessions are really used to coach practice within their own natural environment in whatever shape or form that might look like. So now that we've defined the different modalities and what we know about each of them, let's talk about how we can think about informing recommendations, right? So really, we know that the research litter is not going to give us too much information. So how do we decide? How do we make recommendations in the best interest of the clients we serve? And ultimately, the recommendation that we would make is to let the three-legged stool of evidence-based practice guide us in this work. So in terms of what that means, if you're not familiar with the three-legged stool, this comes from Sackett back in the 1990s about thinking about what evidence-based practice is and how do we define it and how do we know we're doing it. To be clear that evidence-based practice is not just what we know from research evidence, right? That is an important leg of the stool, as you can see here, which is the best scientific evidence that we have, the results of empirical studies testing the efficacy and effectiveness of treatment. But there are other things that contribute to good practice. And the second leg of the stool is clinical experience, which we'll also get into and talk about more. And then, of course, we want to be really thoughtful on considering what our patients' preferences are, our clients' preferences are for treatment and treatment goals. And it's only the integration of all of these three things that would consist of evidence-based practice. So I want to talk a little bit now about how each leg of these stools can inform our decisions for and recommendations for treatments for anxious youth. So in stool leg number 1, this again refers to that research evidence. So what do we know about how research evidence can support decision-making around treatment modalities? And what we know from the research, some of this is recapping a little bit of what I mentioned before, is that the randomized controlled trials that have been done, right, where they randomize to receive either telehealth or in-person services, those studies generally demonstrate equivalence. So there's the same outcomes if you got telehealth or if you got in-person treatment. That's sort of on the whole. And then there are mostly small studies, but all of the studies done with youth do also support this idea as well. There's also a lot of work that has shown that we can have increased attendance or engagement via telehealth, but I would offer a little bit of a caveat on that, which is that most of that data comes from the peak COVID-19 era when kids were stuck at home all the time. And at least I can say from my own personal experience, I see that we don't see quite the same boost in attendance at this point now that kids are back in activities, that they're back out of the house, that parents are back at work outside the home, that there's still some benefit to attendance for telehealth, but not quite the same way when kids had absolutely nothing else to do except show up for their therapy session. But critically, there are a lot of limitations of the existing research base, and I will highlight just a few that I think are important for us to reflect on. First, the studies have been small, and what that essentially means is they haven't been able to do any type of subgroup analysis to determine, are there some kids that do better over telehealth versus in person. And we don't really know that data. All we know are those mean differences, that it tends to be the same no matter what form you got. As is true with most randomized trials in mental health treatment literature, there's very limited client diversity in most of these samples. So it's primarily white, middle-class, homogeneous populations, which of course limits the generalizability of findings in terms of thinking about who is appropriate for telehealth and how effective telehealth may be. And I think it's important to note too that one of the few studies in this area actually had 11 families decline to participate because it wasn't amenable to them to be in either telehealth or in person, right? So we know there's some preferences there among families that makes some modality choices difficult. Like I said, there's no data on hybrid treatment. So essentially, aside from knowing that telehealth may benefit you, the research evidence isn't yet advanced enough to really support definitive decision-making around treatment modality recommendations. And so given this lack of research, the second and third stool legs becomes especially important in thinking about guiding decision-making. So that brings us to stool leg number 2, which you'll remember, as I mentioned, is clinical expertise, right? So how then can clinical expertise support this decision-making? Now, before we get into that, it's important to say, what do we mean when we say clinical expertise? Typically, we're talking about a combination of both a clinician's own experience and their own clinical judgment about a given clinical situation. And clinical expertise can be both collective or individual. And collective clinical expertise refers to kind of like published wisdom of what people think works. So this is like consensus statements from experts or surveying providers about what they think has been most effective. I'll refer to that as collective clinical expertise. And then there's individual clinical expertise, which is what do you see working well via telehealth for the population that you tend to serve, right? As individual providers, we know our populations best. So that's the individual expertise that we bring to the table. Where does it work? Where does it not work? And how do I incorporate that into my recommendations? So let's dive a little bit deeper into each of these. So first, in terms of collective expertise, that published wisdom that's out there about what works better in terms of telehealth versus in-person, there is a recent study that served practitioners who exclusively provide, not exclusively, but predominantly provide exposure therapy or exposure with response prevention. That's the ERP that you see up there. And these practitioners reported through this survey that in general, they found telehealth to be more feasible with individuals who had milder symptoms compared to those who had more severe symptoms, right? So in essence, saying in-person's better from their perspective for kids who are more severe, and telehealth is better for individuals with milder symptoms. They also found that they felt that it was more feasible with adults compared to kids. And in terms of individual expertise, I'm going to offer on this, the next couple slides, just what we've observed in our clinic in terms of over the past couple of years since we made the shift to doing telehealth. Who do we think telehealth tends to work well for? Who does it not work well for? So the information I'm presenting on the next 2 slides is not data per se, but rather the clinical wisdom that we have observed over several years of doing this work. And in terms of what we found, or what we find, is that telehealth we find tends to be less suited for certain particular presentations, in particular selective mutism, where kids talk easily at home with maybe a few preferred family members and friends, but are unable to talk or unwilling to talk in other situations like at school or extended family members or with certain peers. As well as social anxiety, where you are having kids have a lot of difficulty in interactions with other individuals, that because the practices or exposures we do for those are so embedded around being around other people, that we sometimes often struggle to gain traction when doing that work over telehealth. We also find, similar to what I showed on the other slide, that kids who present with more severe symptoms seem to struggle more with telehealth. They don't progress as effectively versus when we get them on site, they tend to do better. That kids who have lower or mixed motivation for treatment don't seem to do as well over telehealth. A lot of these, as you'll see, are very reflective of many of the things y'all put into the chat at the start of our talk today. So just want to validate and name that you guys are spot on. Kids who have some comorbidities that may limit engagement, right? Difficulties with sustaining attention or ADHD diagnoses, and also kids with significant depression symptoms also seem to struggle over telehealth. And obviously, in some families, caregivers may struggle to provide oversight that's needed for a treatment to progress effectively. And especially if kids have limited private spaces or don't have access to appropriate technology. And in particular, when kids are accessing telehealth over the cell phone, we find that that also tends to limit progress and seems to be much more difficult for both the clinician and the client to feel like treatment is being helpful. In terms of who we see telehealth working really well with, we tend to see it work well, particularly for kids whose symptoms are exacerbated when they're at home. Like I mentioned earlier, kids who struggle with contamination at home have a lot of opportunity to do naturalistic practice when they're on a telehealth session. Or let's say they have a lot of anxiety with homework or working on the computer, right? You have the ability to really be there with them where they experience the anxiety. And telehealth works really well for those kids. In addition, if kids have transportation issues where it's either you're doing telehealth or they're probably going to drop out of care, we tend to see telehealth working better, obviously, than in person because it's something better than nothing. So in terms of wrapping up stool leg number 2, I do want to highlight that there are some limitations that are known about our own clinical expertise, and in particular, that it's considered very susceptible to bias. And in general, like even though the data suggests on the whole that telehealth and in-person therapy are effective, only about 80% of clinicians will feel that it has the potential to be as effective as in-person therapy, which is a mismatch from what we know from research data. And in general, we also know that clinicians tend to be less positive about telehealth than the clients that we serve. So it's important for us to just be mindful that we want our clinical judgment and our clinical expertise to inform recommendations, but it can't be the only thing that's informing the recommendation because of this potential for bias. So we want to integrate it with stool leg 1 as well as stool leg 3, which I'll move into now. So stool leg 3 is really the client or patient preference, characteristics, and values. And in particular, when we get to this place, we'll talk about how we really want to learn what's important for our patients and really think about taking a collaborative decision-making approach that's particularly relevant when we're thinking about recommendations for telehealth versus in-person care, especially given the limited research data that we have and the biases that we know are associated with clinical judgment alone. And there are a lot of facets of a family's background, their preferences, their environmental context, their values that can and should inform treatment delivery and our recommendations. So I'm going to talk about a few very salient client factors. I'm not going to say that these are exhaustive of all things that you might consider when making an in-person versus telehealth recommendation, but these are 3 that we think are particularly salient. Client and family perceptions of how effective telehealth is going to be, logistical and environmental barriers, either to in-person or telehealth care, because we know they can be both, as well as client and family comfort with in-person sessions. Excuse me. So let's talk about each of those in a little bit more depth, starting with client and family perceptions of telehealth effectiveness. In terms of what we know from studied papers, families generally report comparable satisfaction and rapport between telehealth and in-person sessions, but we know families will also vary. And particularly if you're working with individuals with OCD or more severe anxiety, there's some mixed perceptions where parents and families may have more specific opinions about what they think will be more effective for their child. And importantly, it's been demonstrated, and it's important to know that an individual family's perceptions and preferences of what they want can change over the course of treatment. So someone may come in and say, I need telehealth, and then change their mind down the line or think it's not as effective, or vice versa. And so it's important that this isn't something we just assess at initial session, but continue to be mindful and think about over the course of treatment. And in our own clinical experience, we've seen families have concerns about telehealth maybe getting in the way of kids being able to connect with their therapist, concerns about their home environment, making it suitable for telehealth, or thinking that, whatever their child is experiencing is not a good fit for telehealth. Even if it's maybe not necessarily something that we as clinicians agree with, families have their own experiences and preferences that it's really important that we listen to and think, because they will have them. And then in terms of logistical and environmental barriers, again, I'm going to break up the differences between in-person versus telehealth sessions. These are all things that we want to be thinking about and assessing for to inform our recommendations, right? In-person, like we know that there are a lot of things that can get in the way of attending sessions, especially for individuals from economically disadvantaged backgrounds, who may have to work long hours, may live far away from the clinic, have trouble with transportation, have limited access to childcare. All of those things typically need to be in place for on-site therapy services to be successful, and we can't assume that they're there, right? So in some ways, we can provide transportation passes, we can provide childcare in the clinic, use case management or connect with case managers alongside therapy to try to overcome them. But in general, if we see these extensive logistical barriers, we start to think in our head, telehealth may be the best fit for this particular family to get them into care and get them the support that they need. And as I'm sure you're all aware, we talked about many of these already. Things we want to be thinking about from telehealth, barriers to prospective telehealth sessions are like, does the child have access to a private space, a distraction-free environment? Are they willing to present on video? Do they have access to a desktop? Do they have stable internet? If not, we're very concerned at that point, right, that telehealth is going to be an effective modality for that child. We also want to make sure that we're thinking about potential confidentiality concerns, right? Ideally, we don't want the child communicating with us exclusively through the chat function because they're afraid of being overheard. We can try to work around that, right, by using white noise apps and other things. But ultimately, if we see a lot of these extensive logistical barriers, we are starting to think in our head, we might need this kid to be seen in person in order for treatment to be effective. And then finally, we do want to try to think about, assess, and understand a family's individual comfort, right, with coming on site in person. The global pandemic has officially ended, but COVID-19 remains a threat, as well as other diseases. And families will vary in their comfort with being around others. We have some families in our clinic who will continue to mask, right, even though it's no longer a requirement in our building for individuals to mask. And this may be particularly pronounced with families who have immunocompromised members. So it's important for us to still be thinking about that as we go through and think about making recommendations. So how do we tie this all up, right? That's a lot of information. It's a lot of things to be thinking about. So let's talk a little bit now about how shared decision-making can really support our recommendations. And when I say shared decision-making, I'm referring to a process where the child, the caregiver, and the clinician, excuse me, are engaging in bi-directional information sharing and having a very collaborative discussion of the pros and cons of starting on telehealth, starting in person, taking a hybrid approach. And so we have that initial conversation, and we'll talk about some things that you can be thinking about during that conversation. And then ultimately, you'll begin with whatever you decide collaboratively, but continue to revisit that discussion and decision over time and make sure it's working. So this shared decision-making process starts at the first appointment, but is something that doesn't end at the first appointment. And it's something we keep coming back to. Just because a child starts on telehealth doesn't mean they're going to be successful on telehealth, and we may need to make a change over time. So ultimately, we would recommend that there's 4 main factors that you want to take into account when thinking about a recommendation of a treatment modality. I did include a QR code here as well. If you follow this QR code, it will take you to the full manuscript where we go into this information in quite a bit of depth. And table 1 in the paper goes through these different factors that I'll talk about and gives you some questions, which I'll go over, but it's sort of a high level review of, if somebody has this, think telehealth or think in person. So you can use this to sort of think through individual clients and say, where are they falling? Does this seem like a client that ultimately is going to benefit well from telehealth, or do I maybe need to think about in person? So let's dive in a little bit more. So in terms of factor number one, we want to first, of course, be thinking about what's in the best interest of my client's symptoms. What's their presentation that they're coming in with? What's their motivation for treatment, right? So in terms of clinical presentation, do they have some of those symptoms like social anxiety or selective mutism that make us worried that telehealth is not going to be appropriate, right? Is the child old enough where we think they can effectively engage in treatment? If not, we're probably going to be recommending they start in person. What are the co-occurring symptoms alongside anxiety that are present? Do they have significant depressive symptoms or significant attention difficulties that again make us concerned about whether telehealth will be effective, that we might want to recommend strongly an in-person approach based on their symptoms? Similarly, with motivation, are they motivated? Or are we concerned that if we do telehealth and there's low motivation, that we're not going to have meaningful impact in treatment? And this is important because we want to give feedback to families about our recommendations, our justification for those recommendations at the outset, so they can make an informed decision about what modality is going to work best for them. In factor number two, we're really diving into those client factors. What is their perceptions of how effective telehealth will be? Do they have a lot of concerns that telehealth isn't going to work for them? If so, we probably are going to start on in-person. Do they have a strong preference for telehealth for logistical reasons or other factors? In which case, they're going to probably come in and want to start with telehealth, and we have to factor that into the ultimate decision. And then, of course, a big bucket that we're thinking about are all of those logistical barriers, right? Can the family get to the clinic? Does the child have a private space where they can do a telehealth session? Are there a lot of scheduling conflicts that would make it difficult to get to a clinic on site on time? Maybe then we're thinking telehealth. Is the caregiver available to oversee the sessions? Do they have the technology that's available? Can the family reasonably come on site if there are siblings that also need childcare, right? All of these things are things that we're thinking about and coming together to make a determination alongside factor number one. What do we think is clinically in the best interest for the child? And then how do we navigate that alongside logistical barriers? And then finally, in thinking about factor four, some key questions that we're thinking about, like, do COVID-19 rates or does the health of the family at that moment mean that they can't come on site and we may need to switch to telehealth? Is there a family who has an immune condition that may increase their vulnerability? Are they willing to wear masks if it's required at the time? These are all things that are important for us to be thinking about, and knowing that it's not just a matter of, well, I think this client's a good fit for in-person or telehealth, that a lot goes into that decision. Before I get into some of the case examples, I just want to talk a little bit about wrapping all of this up together, right? So let's say that we've gathered our information and we want to then have that conversation, that shared decision-making process with the family that will ultimately lead us to come to that initial decision. And I think one thing to keep in mind is we do need to be prepared that our recommendation or our clinical preference for what may be in the best interest of the child may not ultimately be what ends up happening in practice, right? Like, for maybe logistical reasons, we think it's really important that a client comes on site, but the family's adamant that that's not possible and that they don't want to do that. In those cases, it's really important to reflect that in your documentation, right? So to be able to say, like, provided recommendation for treatment modality for XYZ reason. However, family expressed concerns that XYZ, we wouldn't be able to make that work. So we decided to proceed with telehealth despite the recommendation from in-person, right? We want that in our documentation. And then we want to also talk with families, especially if they're making a choice that maybe is disparate from what we're recommending, asking, can we revisit this in a few months and make sure that your child's progressing the way that we want your child to be progressing? And if in a few months things are going great, awesome, I'm so glad we made this choice. And if they're not, maybe we can revisit whether it's possible to come on site a few times a month so that we can make more progress with your child. So I'm at this point going to move into some examples to try to bring these principles to life. I know there are some questions coming in the chat. I promise we will save time and I will get to them as we go through. But I do want to spend a little bit of time walking through some examples to try to bring this to life because it's been a little bit technical so far, I know. So let's talk about this first case example. All of the examples I'll give, they are not real cases. They're more like amalgams. They're adapted and adjusted from real cases that we've seen just to preserve client privacy. So let's take this first example. This is a 13-year-old bilingual Asian American male who has both obsessive compulsive disorder and generalized anxiety disorder. In terms of his clinical presentation, he has a lot of concerns with contaminants and a lot of rituals around washing and cleaning. He also shows excessive perfectionism and spends about 6 to 8 hours on homework a night to the point that he doesn't sleep well because he's spending so much time redoing his homework out of fear of making mistakes. He also has a history of self-harming when his stress gets very high. And there's also a lot of high family stress among this family, including diagnosis of OCD in the mother and some unspecified anxiety within the father. So in terms of the treatment progress for this family, this is a family who initiated treatment during COVID-19. So telehealth was the only modality available to them when treatment started. So we didn't have a choice, right, when they first began treatment. And they ultimately, he showed some mixed treatment engagement over time. So he came, a lot of no-shows or showing up late, but he mostly engaged, and there was some benefit. So he did exposures, and he did them for a number of sessions, and it worked somewhat, but he wasn't where he wanted to be, and he wasn't making the progress that we would have hoped to see for a child with that type of presentation. And this family in particular had a very high degree of COVID-19 specific fears because they had family in Wuhan, China at the outset of the pandemic, and they were very traumatized by what they had seen and heard from their family. And so they were very, very, very unwilling to consider a switch to in-person. So I'm going to throw some things out to all of you to maybe start putting some things in the chat. So if this is your client, you have a client who's not showing treatment engagement well. They're not making the progress that you want to see over telehealth, and you want to bring up the idea of switching to in-person. What are some things that you would be thinking about or concerns that you would have about this family, about either continuing with telehealth or what your concerns would be about switching them to in-person? So just start throwing some things out in the chat. You can take either question. What would your concerns be about continuing to do telehealth, even though we have a lot of concerns about how effective it is? Or what would your concerns be about bringing this individual on site? And I'll give it a minute for things to come through. Emotional safety. Okay, so yep, being in person could cause additional anxiety. Excellent, right? So what would it mean to come on site? Keep things coming in. Now, these are great suggestions, great things to be thinking about. Right. Okay. So high family stress may impede telehealth treatment. And we're concerned about bringing people on site. We're concerned about people potentially dropping out, right? The child dropping out if we continue on telehealth and having it not be effective. What about if coming on site makes treatment worse, right? What if coming on site makes their anxiety worse and then leads them to drop out of treatment at that point, right? So this is what makes this work so tricky. Thank you all for sharing those concerns. I think they're spot on, right? We have concerns about continuing on telehealth. We have concerns about switching modality. It's not necessarily a clear answer. And what I think is so interesting, right, is worsening anxiety and dropout are risks of both, right? So what do we do? And that's where that shared decision-making ultimately comes in. And I'll tell you what we would do in this situation in our clinic and how it panned out in this sort of hypothetical example. again, drawing from real clinical experiences, is ultimately what we ended up doing with this family is having an open conversation about our concerns and really eliciting from the child, from the family, all of those things that you're sharing so beautifully in the chat, right? Like, what are the concerns about coming on site? And then us sharing, like, I'm concerned that if we don't make a shift, that you're going to drop out of treatment because it's not working. We're not seeing it work the way that, we think it could work if we were able to maybe have you on site and get a little bit more, like dig in a little bit deeper to some of the things, because the computer makes it a little bit hard to focus all the way. And ultimately, what we recommended was a trial on-site therapy session, right? So can we try one on-site session and see how it feels, and then reassess from there, right? And so it was actually an exposure for the family, both the child and the parent, to come on site. And we framed it that way to them. It's like, let's try it. Let's see how it goes. And ultimately, the family was able to successfully come on site, but then also felt like it was stressful for them, and they chose a hybrid model, right? So we ended up saying, we're going to do mostly telehealth, but we're going to have you come on site every once in a while so we can really make sure that we're making some progress in the best way that we can. And that worked really well for this individual, to the point that they successfully graduated treatment. But it was tricky. And interestingly, the first time that we had the conversation, they didn't want to come on site. We had this conversation multiple times. The first time they said, no, we want to continue on telehealth, but then he still didn't get better. And then we had that conversation again a couple of months later. And at that point, they were much more willing to consider coming on site, because they were frustrated with the lack of progress, and they were seeing the things and the concerns that we had raised. And I think that kind of emphasizes how it's not a one and done conversation. We keep having the conversation. We keep getting family feedback to be able to help clients get to where it is we want them to go. Let's talk about a second case example as well. So in this example, and again, I'm going to pose the same questions to you in the chat, so get your gears working as I walk through this. Let's say you have a 9-year-old female who has generalized anxiety disorder, obsessive compulsive disorder, and attention deficit hyperactivity disorder. In terms of the specific presentation, she had a lot of health anxiety, a lot of worry that she was going to have like a cardiovascular event or a heart attack and maybe die or have a stroke. Was doing a lot of checking online about health-related issues, as well as making sure that she wasn't having a stroke, right? By like putting up her hands and making sure there wasn't asymmetry. So a lot of compulsions and checking behaviors in that way. She also had a lot of compulsions related to evenness and symmetry, and a fair amount of interpersonal stressors. A lot of family change going on at the time, including a lot of parental conflict in the home that was complicating treatment, and something that was also needing to be addressed. And importantly, there were other individuals within the family who were also experiencing both anxiety or OCD symptoms as well. This individual actually had started treatment before COVID, and was in maintenance. They're actually doing really well when the stay-at-home orders first went into effect, but they had a major increase in anxiety when COVID started, and they had a rapid decline in engagement when we went from telehealth, from when we went to in-person services. And there was very clear evidence that this child was not paying attention, right? They were playing video games in a different tab on the computer. And because of the family stress and other difficulties in the home, the caregivers weren't able to provide the oversight that was needed to really maintain attention. So if this was your client, what do you think probably needs to happen clinically for this child to improve? This is not a trick question. What do we probably need to recommend to this family that they do to be able to see progress for this individual? Throw it in the chat when you can. Do we want to continue on telehealth, or are we thinking we probably need to make a switch? Yes, exactly. Thank you. We need to make a switch, right, to in-person sessions. However, the family family tells you they can't make it work, right? That they understand, they acknowledge that in-person services clearly are needed. However, because of the family stress, because of what's going on, they can't come in. So at that point, What are you thinking? What do you do? How do you handle the situation? How are you going to support this child? What might you want to be talking to the family about? And what might you want to be doing in your own practice to try to move things forward? How would you proceed? And again, please feel free to throw things into the chat, because we struggled with this, right? And I'll share how we ultimately resolved it, but I don't know that there was one right answer here. So I'm curious, let me hear from you based on everything we've talked about, based on your own clinical expertise and experience. What might you be talking to this family about? And what might you want to make sure that you're doing clinically to help this child? All right, so we have one person offering that you could like double down on efforts, right? To eliminate distractions at home, make the therapy you're doing, really work with the parents, right? Exactly, spot on. You're finding essentially new treatment targets, right? Working on parent engagement, trying to get them more involved in sessions to see if you can make telehealth work. These are all excellent suggestions. And it ultimately, I see someone saying it's really hard. It was really hard because ultimately in this case, the family was able to do it a little, but really not enough. To the point, actually, that we were concerned that therapy was no longer helpful and, in fact, had a potential to be harmful, right? Because the child was getting nothing out of it. She hated coming. She was starting to hate therapy. That's obviously not something that we want. And so I see somebody saying we need to continue conversations about the possibility of in-person. And I love that. That's exactly what happened. We tried and we continued to have those conversations. One thing I didn't see come through in the chat that I would acknowledge is with a case like this, it's really important from a documentation standpoint to be clear that we document that we had this conversation. We wanted the child to start coming on site and the family declined our recommendation. And so we were continuing with telehealth. In case you're ever audited, it's good CYA practice, and it's good for understanding the progression of a child if we're looking back at a chart and trying to understand why someone's not engaging successfully. And ultimately, we had an updated conversation about our concerns about continuing, about whether treatment would be successful and whether we felt like it'd be beneficial to continue, to the point that we actually said, we're not sure telehealth makes sense. And we think we either need to switch to individual, like on person, or figure out something different to support you because we're concerned that what we're doing is harming and that's not what we want to do. And at that point, the family elected, actually similar to the first case example, to do a hybrid model as well, where they started to come in every other week to be able to get the child more support. And actually the other weeks were spent in parent sessions over telehealth, so that we were really addressing the family things alongside the child work, but that all child work was taking place on site. But it took, again, a long time, and it was I don't remember who it was who said it's difficult. It was a very difficult, stressful situation for the clinician. And I think I'm sure many of you have experienced similar situations as well. It's stressful for us, and it can take time to get to where we want to see kids be. And sometimes that means saying, I'm not sure continuing is in the child's best interest. So I'll wrap up with one more example and then open it up to questions. So in this third example, this is a 12-year-old with generalized anxiety disorder who demonstrated a lot of excessive worry, a lot of perfectionistic behaviors, and some behavioral rigidity around like needing things to be a certain way. Ultimately, the intake evaluation suggested this was a relatively uncomplicated case, right? They had a very high degree of family support, very highly motivated for treatment. This is the kind of case that clinically we think is ripe for telehealth, right? Like this is an excellent case to be seen on telehealth. However, the family was absolutely adamant about in-person services, right? They were convinced that telehealth wouldn't be effective for their child, but the child needed to be seen in person. And to complicate it, because I think this is important to mention as we all navigate hybrid work schedules, many of us, right? Let's say this individual only had availability for therapy with a clinician on a day that the clinician planned to work remotely. So you have a conflict here, right, between the clinician's schedule and what's available and what the family wants to be done. So there are a few options here, right? We could say we don't have any in-person appointments available. We could have the clinician come on site just for that session to be seen in person, or we could have the client seen virtually by the therapist on their virtual day, or they could wait for another clinician appointment to be available to be seen in person, right? So to recap, great fit for telehealth, they want in person. They have a particular availability for those in-person services that there's only one available slot for, right? We all know how hard it is to get those after-school appointments in. And that's the day that the therapist works remotely and they don't want to come on site to do an in-person session. What do we do in those instances, right? Like this happens. This is a real thing that occurs is there's conflicts between our own preferences as clinicians for our work schedule compared to what the families may want to have done. So I'm curious, what are your recommendations? What are your thoughts? Please throw them in the chat about how you'd want to proceed in this instance. And then I can share sort of how we ended up working in this particular example, but just to illustrate the complexity and nuance that can go with these types of considerations and decisions. So someone's offer, it says, offer to start now with telehealth. If it's not working, then they move to an in-person slot when available. Excellent. Yeah, I think that's a really great recommendation. Any other ideas for individuals that are spinning their wheels about how to do this? Also providing education about how telehealth could benefit them for this child's needs. We could fluctuate or alternate in-person and telehealth. I think these are all great suggestions. And ultimately, what we would do in this type of example is really go back to that shared decision making, right? So this is a conversation. We can make a recommendation and work with the family. We want to lay out the options, the pros and cons. So being clear that we actually think that this child will do really well on telehealth, and we've seen other kids with her similar presentation do really well on it. And we understand they want in person, although unfortunately the only slot we have available right now is a virtual slot. We could also put you on the wait list, right, for the next available slot for in-person at that particular time, and really work with them about what is it, how would you like to proceed? And I can tell you, like, my recommendation would be to start virtually because I think she'd do well, and then switch, right? But ultimately it's the family's choice about how they want to proceed. And again, it comes down to making sure that we document it, potentially revisit it. And I think that the sum here that I would land on is it's never a one size fits all. We always want to work closely with the family to really understand and share our perceptions, get their perceptions, and then work together to come up with a plan, document that plan, revisit the plan over time. All right, in terms of keeping myself on track with time, I'm going to wrap up just by sharing one of the things that I do in my work is try to develop resources for clinicians to help them do exposure therapy because it can be really hard and challenging. We have a website called bravepracticeforkids.com. It is a toolkit to support clinicians working with anxious youth. It is freely available. It will ask you to create an account. That's just so we can push out things and let people know about updates, but otherwise it is freely available to use. And then also, like I said, we have a lot of information and more examples about all of the many of the topics I talked about in the manuscript here, which is also freely available online and can be accessed through the URL here or the QR code. The next couple slides are references, which you will have access to the slides, but let's stop there and move into Q&A.
Great. Thank you so much, Dr. Becker-Hames. As you said, yeah, we're just going to move into some of the questions now that did come in. We do have some time for questions. So again, I just do invite folks to send in their questions through the chat at this time. So let's see. One of the first questions that came in, as you were covering the advantages and disadvantages of telehealth for youth exposure therapy, someone had a question in regards to how can you assure safety during exposure?
I love that question. I saw that come in, I think, when I talked about going on the bus with the client. And this is a really tricky part about exposure work. We can't. I mean, part of life is that there is inherent risk. So we do what we can, right? We want to make sure that anything we're asking somebody to do within the context of exposure, whether it's in person or over telehealth, is ultimately as safe as can be. But we can't ever guarantee safety because there are things and life forces outside of our control. What we do tell kids is that exposure is something that we would never do to you. It's something we do with you. I'll never force you to do something. I would never ask you to do something that I myself wouldn't do. And typically, often in the context of exposure, I'm doing it first to demonstrate that I do think it's safe before they do. Um, and really emphasizing that, we think about it a little bit like getting into a cold pool, right? I'm not going to push someone into the deep end. That will be really overwhelming, especially if they can't swim yet, right? We might have to teach some skills. But what I'm going to do is I'm going to start with dipping my big toe in. And then when that gets better, I'm going to put my foot in. And then when that gets better, I'll go up to my knee and taking it step by step. And each step may not be fully comfortable, but it's not going to be shocking. It's not going to be overwhelming. I'm not going to intentionally put you at risk. But ultimately, you'll get all the way into the pool and be able to do things that you can't now because your anxiety is getting in the way. So a long way of answering the question, the simple answer is you can't, but the complicated answer is we don't ever design an exposure practice that would intentionally put somebody at risk for harm. And it comes down to values and goals. If the child needs to take the bus every day because that's how they get to school, and if it's something they would be doing anyway in a routine setting, it would be considered appropriate and ethical to do within the context of exposures. If it's having them take a walk in a neighborhood that's objectively dangerous where there's gang and drug activity, no, we're not going to do that. And that comes down to working with the family about what their goals are and what their values are and what they want to achieve in the context of exposure, and building and designing the exposure exercises around that. I hope that answered that question.
Yeah, great. Thank you. I do appreciate the examples that you give, right, in terms of how to have this conversation with youth. I think for some folks, we might think, oh, well, they're young, they don't need the full explanation or whatnot, but your sort of value to transparency, right, and being honest with youth and young kids because they are very astute and they know what's happening, right? So thank you for that. Really appreciate that. We also had another question come in around motivation. So how would you engage a youth or even adult who is not motivated to talk while enrolled in telehealth services?
Yeah, that's a tough one. And I think with telehealth in particular, I will just say, like, I also find it's harder to get kids to talk who don't want to talk. If they're younger, sometimes we can do some scaffolding with parents in the room so that they talk to the parent, but maybe more odd, like that we hear it versus talking directly to you and then working your way up step by step to be able to talking directly to the clinician over the telehealth platform. And then obviously the other main way that we often motivate, especially younger kids, is with rewards and incentives. So potentially working with the parent one-on-one to develop an incentive for making audible noise over the telehealth platform, and then working with the parent to maybe doing like a visual sticker chart to have the child work to earn some type of prize or privilege, whether it's extra screen time or getting dessert or getting a play date with a friend, whatever is motivating to the child. And trying to work on incentive structures in that way. And that's when I should say those are examples that I would say work well when there's sort of a fear-based thing about speaking and maybe talking to somebody new, and maybe having them start by nonverbal communication and then working their way up. Again, emphasizing providing praise. It's actually doing exposure with kids on that gradual exposure, but specifically focused around speaking on the telehealth platform. There have been instances, at least in my own practice too, where the fear of speaking over telehealth is not necessarily because of social anxiety, but is more out of a concern of being overheard by other individuals in the home. And that sort of begs for a slightly different approach, right? So if they're really concerned that like their mom's going to overhear or is like listening in, maybe there's some boundary issues within the family and they're communicating with you in the chat because of that. In those cases, that's often when I talk with the parents about the importance of privacy, setting up white noise machines in the home. And if those aren't working, I'm starting to have a conversation about coming on site because otherwise therapy is not going to likely make much progress. Using headphones, obviously, like the workarounds, but if it's not working, then that's a conversation to have with the family.
Great, thank you. And another question just came in. What would be considered an appropriate age for a child to be considered for CBT or other treatment for anxiety? And I guess I would maybe also ask, I know you had mentioned that a lot of your work is around assessing for anxiety. Around what age can we even start screening children for anxiety? And then how do we move to what is an age appropriate treatment modality?
Excellent question. we do exposure work starting as young as 4. Most typically, you'll see kids start around like 6 or 7 when they're doing more like individual CBT. So we start screening young. I would say like 4 is usually the earliest age where we get kids, although every once in a while we get a 3.5-year-old, although that's very, very rare. And even 4 can be rare. Most anxiety, when you ask kids sort of retrospectively, starts around like elementary school age. For many kids, sometimes it doesn't start till middle school. So there's lots of different ages where we can catch kids, but certainly younger than I think many of us think. And CBT, sort of classic CBT, right, where you're talking about thoughts and feelings and then having kids do individual practices, is usually designed for kids 7 and up. But there are family-based protocols that we often use for kids with anxiety and OCD who are as young as 4. And those involve both working directly with parents as well as working with kids directly to help them do practice exposures. Beginning at 4, assuming they're sort of verbal. I think if kids are nonverbal, that's when we don't typically employ CBT strategies at all, like kids who are completely nonverbal with very low IQs. Sometimes we're looking more at more straight behavioral work in those instances rather than CBT or exposures.
Great, thank you. And any suggestions on school avoidance? So we actually, I believe it was last month, or if not, actually early September, we did do a webinar on school avoidance because we are seeing a lot of that increase. But the question that comes in is any suggestions on school avoidance and no access to virtual learning post-COVID when telehealth was an option?
Right. So it's interesting. That's such a good question. I think, well, with school avoidance in general, like as Diana, as you mentioned, that's a whole process, right? It comes down to like, what's the function of the avoidance, right? Are you avoiding because of anxiety? Are you avoiding because you get to stay home and play video games and it's more fun to be at home than it is to go to school? Combination of both? Is it something else? In terms of treatment, I think the exposure work sometimes telehealth has been a real asset in some of those instances. Like I've done telehealth sessions while kids are while they're on their way to school and they don't want to go in, and I can coach the parent to support the child or talk to the child directly right before they go into school versus I think previously, right, we would have maybe planned it the day before and sort of let things go, but telehealth lets us be there with the person as they go into the school building. That's been helpful. And I think one of the tricky things is it's actually made it harder to avoid school, right? If you can't just attend virtually, it was almost incentivizing for a while. And I think we might want to, like with kids, name that, like that, it used to be like you could avoid school and it was okay. And now it's not okay because you can't just show up in a virtual class. And really work with the child to understand if there's an anxiety component, what is it that they're afraid of? What is what we will call their core fear that's making it so scary and hard to go to school? Is it about being judged by others? We need to do practices around, potentially learning to be around others successfully. Is it about grades? Do we need to do practices around perfectionism and performance? Is it about an undiagnosed learning issue that's making school really challenging, right? That points us in a different direction. So it's a great question. And I think it's just not a one size fits all. So, and probably could talk for an hour about that question, which I'm not going to do. But I think ultimately it comes down to knowing what is the reason the child is avoiding, and how can we develop a plan that gets them gradually back to doing what it is that they need to do. And then there's, like I said, there's a role for telehealth in many cases to make that even more successful than traditional in-person work, especially if you can't go right on site, if you're not in a mobile capacity, where some clinicians are, right? You can go out, others can't. So the telehealth can be your best friend in those ways.
Great, thank you. Appreciate that. So for folks that are maybe seeing an increase in school avoidance, that webinar was back in September. Certainly feel free to go on our website and look for it. When children and adolescents do not go to school, terminology and assessment. And it does go a little bit deeper into what you just mentioned in terms of what's the function of the school avoidance, right? Because I think, as you said, that will dictate where you go. Is it anxiety driven or is it something else? So I think maybe listening to that one might be helpful for folks out there. And in the interest of time, maybe we could just get one question, and I certainly mean to do no just putting it towards the end, but seeing if you can maybe address this briefly. But you did mention in most of the studies were not included were BIPOC participants, so Black, Indigenous, or people of color. Can you speak to what you might anticipate are cultural considerations when suggesting or doing telehealth with youth?
Yeah, I mean, I think when we talk about some of the limitations, a lot of them tend to fall more into like the economic disadvantages. But there may also be cultural expectations around, can telehealth be effective? People have different preconceived notions about what therapy is that can really vary depending on your cultural upbringing and understanding. I don't In our work in our clinic, we are 50 to 60% BIPOC, and we don't see that negatively impacting treatment. So I'll say, we have some data that we have not yet published, but basically showing that we don't see differences in care, either in telehealth or in person, based on sort of racial ethnic background. And I would say, like, clinically, I think that you can certainly do telehealth, and it's more this person-centered approach, right? Like, people will come and they will have concerns about whether telehealth will work, about whether they have usable internet at home based on potential circumstances or contextual factors that they have. And so ultimately, we might think about who were those people in those studies who like didn't make it into the study because they couldn't make it, they couldn't commit to both, right? You had to commit to both options to be in the studies. And that may mean that the treatment might need to not just be exposure focused. You might need to bring in other things, because if they can't transport to therapy, maybe there are other transportation issues or other logistical issues that warrant treatment focus, or family stressors that we also might want to be thinking about in terms of family sessions over telehealth. Like, we didn't talk at all, right, about you can have parents call in from work. One is at work and they call in while the other is at home. Like, it allows you to bring people together and collaborate. And in many ways, telehealth is actually touted as a way to increase access to individuals who historically are not reflected in our mental health treatment literature. So the data aren't there, although there are sometimes where I'm very concerned when the data is not there, that means that we can't do it. I don't know that that's the case here. I think we still, no matter what, need to be very thoughtful that, like, it works on the whole, but we don't know that it'll work for this person. And we need to learn what this person needs, learn what this person wants, learn how their cultural contextual factors will impact how helpful a particular modality is supposed to be, and really engage with the family about their perspectives, being mindful of any biases that we may be bringing in as providers as well, and not letting those like sort of run the show. So I think that's a complicated answer. And I think I answered your question. I would say, like, take it person by person.
Mhm. Great. Yes, thank you so much. So I know we are wrapping up. On our next slide, I do want to just point out that we have a couple of other events coming up. Understanding and treating complex comorbidity for ADHD and PTSD. That's next week. Another focused on peer support groups in December. We do have other offerings in the works, but have not been announced yet. So again, please be sure to check your emails for announcements and our calendar, ctacny.org. And also, please be on the lookout for a new podcast for practitioners by practitioners titled Voices from the Field. That should be coming out shortly. On our next slide and final slide, you will see that there is a link to a survey. Again, please, it'll pop up, but if it doesn't, please check the link. Your feedback certainly helps to inform our future offerings. I do want to say thank you on behalf of CTAC to you, Dr. Emily Becker-Hames, for your great presentation. We did see a lot of thank yous and great presentations, comments coming along. And I do also want to thank you, our audience, for attending today's webinar. As we close out, I did mention, please take a moment to fill out the very short feedback survey. Visit our website to access trainings and resources. Again, this recording and the slides will be available in the next 2 to 3 business days. So again, please feel free to revisit that. And if you have any questions, please contact us at ctac.info@nyu.edu. On behalf of CTAC and our presenter, thank you for joining us today, and have a great rest of your day. Goodbye, all.
Thank you so much.